Okay, why don't we get started? Again, thanks everyone for attending our Lunchbox talk today. Our featured speaker is Chase Cannon. Chase Cannon is an acting assistant professor in the Division of Allergy and Infectious Diseases at the University of Washington. He received medical training at the University of Texas, Southwestern, and Tulane University before coming to the UW for his fellowship in infectious diseases. He also completed an MPH in epidemiology here at the UW. His clinical practice and research are based at Harborview and focus on HIV and STI care and prevention for the LGBTQ+ and other socially marginalized populations. He recently became the co-director of the Public Health Seattle and King County Sexual Health Clinic, where he oversees the HIV PrEP program. Welcome, Chase. I also want to carry on Susan's tradition of sharing a fun fact about our speaker. And the fun fact that Chase provided is that he is a collector of shoes, and at a recent point in time, he had 175 pairs of shoes, which I was completely flabbergasted by. But thank you for sharing that, Chase. So welcome again, everyone. I'm going to turn it over to Chase, and you can put questions in the chat, and otherwise we'll just leave time at the end and you can take yourself off mute and ask your questions.
Great. Thank you, Roxanne. Thanks, Susan, for the invitation and allowing me to speak to you today during your lunch time. So I wanted to just share a little bit about how this wild ride we've had with monkeypox here at the Sexual Health Clinic. This is not going to be a talk focused on clinical management as much. I will talk a little bit about that, but mostly focusing on just the processes and how things have come about over the last couple of months, which seems like it's honestly been much longer than that. So let's show you here just a little bit of an outline. I will talk about monkeypox as an overview, some history, epi, a little bit of the clinical manifestations, talk a bit about therapeutics and prophylaxis, but I want to spend most of my time talking about how things have gone for us in the Sexual Health Clinic, what we did, what went well, what did not go well, and then just mention some ongoing challenges and steps. And as you saw on the previous slide, I have taken a couple of these slides from others who have done similar talks, so I appreciate that. So, in just talking a little bit about the history of monkeypox, many of you may be aware, but for those who are not, this is not necessarily a new disease. So, was discovered in 1958 in monkeys that were being shipped from Singapore to Denmark. And then we had the first human case about 12 years after that in the Democratic Republic of Congo. And since then, there's been sort of endemic levels of monkeypox in Central and Western Africa, with some sustained human transmission being reported in the early 2000s. And then in the United States, we actually had an outbreak associated with prairie dogs that were co-imported with giant Gambian rats. And so that was actually, so how do people kind of thought about monkeypox as a zoonotic infection, although there were human-to-human transmitted cases in Africa. And then moving forward about 15 years in Nigeria, there has been sustained transmission there. And actually, some physicians that are affiliated with the Ministry of Health have been trying to get messages out saying, hey, we're seeing some new cases, things look a little bit different. Maybe it's because there has not been as much smallpox immunity in the population as we sort of routinely stopped vaccinating people for smallpox around 1980 or so in most countries. And maybe it's because people have had more interaction with animals. But I think that was maybe the harbinger for sort of what was to come, which is now this global outbreak we've had since the beginning of May, with cases first reported in Europe and concentrated among men who have sex with men. So what is monkeypox? It is a virus in the orthopox virus genus. So it's in the same sort of classification we think about for the virus that causes smallpox, as well as the virus that was adapted for the smallpox vaccine. So it is a DNA virus, and there can be sort of large numbers of viruses with variable pathogenicity in this family. and a big host range because it is a DNA virus. There are two clades that we kind of think about. Clade number 1 was formerly known as the Central African clade. That is associated with a lot higher mortality. That is not the clade that's currently circulating, which has now been renamed by the WHO as clade 2B, or formerly the West African clade. Historically and also in the present outbreak, the mortality is pretty low. It's less than about 2% or so. There have been fewer than 10 deaths worldwide in non-endemic countries so far during this current outbreak. And then there was one confirmed death in a person in Harris County, Texas, that had monkeypox, a very immunocompromised person. And then there's another case that's being investigated in Los Angeles County. So potentially 2 deaths, at least in the United States. So the question arises whether monkeypox is actually considered a sexually transmitted infection. And I think depending on who you ask, opinions vary on that. So the infection can be acquired through close or intimate contact, which does, of course, include sex in many instances. But we know that there are other classically sort of named STIs like syphilis that can be transmitted in other ways. So for instance, congenital syphilis being transmitted from birth parent to child. And then on the flip side, we can kind of think about other diseases that we know can be transmitted, for instance, through foodborne mechanisms or from mosquitoes, but also can be transmitted during sex. Do we consider those STIs? So things like Zika virus or Shigella. It's an open question, but you can see here on the left the ways that have been identified in terms of possible transmission from monkeypox. But I think the most dominant form right now in this current outbreak is likely sexual. That's mostly what has been reported in sort of communicable disease interviewing and trying to get at exactly what's going on for this outbreak. So can't have a talk without a CDC epigraph. This is the total number of confirmed monkeypox cases in the United States. As of Friday, I did not update for this morning. So just over 21,000. We are now the country with the most number of cases in the world. I mean, you can see listed here in sort of the darker blue colors where the most cases are concentrated. So a lot of cases in Texas and New York, I think, has sort of led the country in number of cases for many weeks. And then when you look at the breakdown here in terms of number of hospitalizations, not many. The hospitalizations that have occurred have been either people who had severe disease or needed pain control that was not manageable as an outpatient. You can see the age, gender, and race ethnicity breakdowns here. I think as we've all kind of heard, the cisgender men tend to be the vast majority of all the cases, although there have been some cases in cisgender women and some trans individuals. And then in terms of race ethnicity, I think it's mostly white people that have been, in terms of cases, reported to the CDC. But it is important to note that Latinx individuals very much disproportionately affected here, making up over a quarter of cases when that is not necessarily the demographic kind of makeup of all of the places where these cases come from. So other questions have come up about whether monkeypox has affected other populations outside of MSM. And the answer is yes to that. So a recent case in an infant here in King County that was being treated at Seattle Children's. And then we have seen a handful of cases in women, I think 4 to date in King County, some associated with potentially sexual networks that are up north, kind of in Aurora, and people who are sex workers. And then as well, there has been at least one report in the literature in Lancet earlier last month showing that there's been human to dog transmission of monkeypox. So there was a gay couple in France who both had monkeypox, and they were sleeping in the same bed with the dog, and the dog ended up developing lesions, and they were able to genetically link the same virus from one of the owners to the dog. So I think pretty strong evidence that that can happen. So in terms of the clinical course, you can see here from the time of exposure until when people develop symptoms can range from anywhere from 3 to 21 days. So it can be quite a long time. The mean for that is about a week or so. Classically, there is a prodrome where people have fever, headaches, can have swollen lymph nodes, feel really run down, kind of like a flu-like illness. And then again, classically after that, a rash develops. And you can see the time frame for that can go up to 4 weeks before the rash is completely resolved. This is what a progression of the monkeypox lesions could look like. So starting with a macule or a flat spot on the skin, then developing a raised area, and then that fills with fluid, initially maybe sort of clear, and then kind of pus-like fluid that would look like these here. And then as that heals, can develop a central crust and then sort of scab. And then once that scab falls off and new skin heals is when people are not considered to be infectious or contagious anymore. I say again that this is a classic presentation because I think that is what we understood the clinical manifestations to be for the epidemic that was occurring in Africa. But this current outbreak, we're actually seeing some distinctive features that are different than we have seen historically. So at least from what I've read in reports and what we've seen in the sexual health clinic, a lot of times people may not actually have a prodrome that precedes a rash. So they may end up having a rash as their first presenting symptom, and then later they develop a fever. It may not necessarily be in that order. And then the rash can be limited to just one body site. So in large case series, they've reported that over half of people have anywhere from 2 to 10 lesions, but we've certainly seen people come in with just a single genital lesion, and that's their presenting sort of sign. Lesions can be in varying stages of development. So people can have a lesion that's already starting to scab over on the genitals, but then getting newer lesions on the trunk. And then also we've seen a lot of tonsillitis or pharyngitis. So presumably a person was inoculated maybe at the site where they were exposed. So if they were performing oral sex, perhaps. Similarly for the anal area, a lot of people having very significant proctitis. So inflammation in that anal area, with tenesmus, which is sort of this urge to defecate and difficulty with doing that. And then a lot of paraphimosis and phimosis, so swelling of the penis, and for those who have it, foreskin, that can be pretty significant for people and may even require a short course of steroids sometime. We're also seeing a lot, of course, as a sexual health clinic, we're doing testing for co-infections, syphilis, herpes, gonorrhea, chlamydia. Have to make sure you do that because we're seeing significant numbers of that, as well as potentially bacterial superinfections. So the skin is disrupted, and is a lot of immune cells are sort of recruited there, so people can get staph infections and things on top of that. So what treatment do we have for monkeypox? Really, we've been leaning heavily on this treatment called tecovirimat or TPOXX. It is an anti-orthopox drug that is provided to us under an expanded access investigational new drug protocol from CDC and FDA. And as such, does require people to complete an informed consent process. They have to actually sign a form. We have to go through a lot of counseling with them before we're able to dispense that. Really the data that we have are in healthy volunteers, and it's really safety data. We don't have much efficacy data at all for humans. It's actually only FDA approved for smallpox and people who had a reaction to the vaccine, not exactly in monkeypox infection. And the criteria that have been sort of laid out for who might qualify are listed on the CDC website, but just in short, people who have severe infections, those who might be at risk for complications, pregnant individuals, et cetera. And you can see a picture of what that looks like here in our clinic, our dispensing area. Most people have to take 3 capsules twice a day for a total of 2 weeks. And the thing that can be challenging to keep up with, and especially if someone is unstably housed or has food insecurity, is it's recommended to take this medication with 25 grams of fat and a 600-calorie meal. So that can be hard for people if they're either on a diet and they don't have access to it, or they just don't have food. So thankfully, for instance, like in the Max clinic, we are able to give people peanut butter to take with them to help with that, but it can be a challenge. There are a few side effects, pretty mild otherwise, and we've seen just anecdotally that it does reduce the duration of illness and can improve people's symptoms within 1 to 3 days of starting. Although we don't have hard, fast evidence on that just yet. I think that's part of what is being ascertained from all of the data that CDC is collecting. And then additional considerations for people, there is a lot of counseling that has to go into this. Part of what has made the evaluations a long encounter and sort of a process that really can be considerable for providers and for the nursing team, et cetera. as you're talking about isolation, how people monitor their symptoms, and then we do have to report adverse events for TPOXX. And then other symptoms, if people have really bad proctitis, we can offer them topical anesthetics, potentially anti-inflammatory medications if they're not bleeding. We recommend that they do sitz baths. And in certain cases, very few cases, we've had to give people opioids because their pain is really so severe. And then you can see for these other anatomic sites what we have recommended. So really, it's just checking in with the patients and them also letting us know when their symptoms may be getting worse, and then us trying to help kind of get them through until they're on the TPOXX medication and it kicks in and their lesions start to improve. So in terms of other prevention strategies, maybe the one you're the most familiar with is vaccine named Jynneos. So it can be given either as a pre-exposure prophylaxis dose or a post-exposure prophylaxis dose. Again, CDC has criteria for who the PrEP has been historically kind of recommended for, but we're not really seeing anybody who's working with these orthopox viruses or animals that are getting it. Really, we're focused primarily on giving it to people who have exposure based on their behaviors in life and potentially sexual exposures. So people who meet the risk criteria that are determined by local health jurisdictions, but informed by CDC. So there's two sort of types of PEP. Regular PEP is for those who after known exposure to monkeypox, and then PEP plus plus, which is sort of a new term that gained popularity with this current outbreak. Those who may be at risk, but have had a possible or presumed exposure based on identifying them sort of through contacts or public health tracing. And then, of course, we always recommend to people that they reduce the number of sex partners that if they can, try to avoid group sex events, maybe not go to the bathhouse if they can do that, screening partners for symptoms, et cetera. And I think that's a really important thing to remember that we should tell people, because we have had people come in for vaccine and say, oh, I'm going to Fire Island tomorrow after getting my first dose. And it's like, hey, you have to remember this is not giving you protection right away. It does take time for your body to develop immunity. And there are still other things that we recommend that you can do to protect yourself, because you can certainly get monkeypox after getting a vaccine. So that's something that we hope to report about and has occurred in our population. So now I want to pivot and talk about what our experience has been in the sexual health clinic. And as I was preparing for this, it was kind of funny. It really did feel like I was like writing in a diary, essentially. It was kind of like all my thoughts onto a page, what has happened in the last several months. And it was really surprising how much has occurred in just a short amount of time. But I'll walk you through a little bit of what has happened and open to hearing questions. I think there is one in the chat here. Okay, so a question about isolation of cases. How easy or difficult has that been for patients? Yeah, that's a great question. I think, initially we were sticking pretty strongly to CDC guidance and telling people they should isolate at home, not go to work, try to minimize contact with other people within the house and outside of the home for the full time. So that could be 2 up to 4 weeks for some people. And I think people were trying their best to do that, but sort of like COVID, people really, say in their life that they can't do that. And it's not feasible for them to miss 3 weeks of work. They need to pay rent. They have bills, they need to get on with their life. And so we try to counsel people sort of on the best practice and what's recommended by CDC, but also recognize that in real life, people are not able to do that. So as much as they can, saying, cover your lesions, wear a well-fitting mask, trying to stay apart from other people in the home, not use the same bathroom, not use the same kitchen utensils, et cetera, cleaning after yourself, and do the best you can. Because I think, it's not reality that people can just sit at home for 4 weeks and not work. I think that just doesn't fly over well. Okay, thanks for that question. So I wanted to just give sort of a brief kind of broad overview of what we as public health, the role that we kind of played in this. So I think, there were a lot of strengths going into this pandemic, second pandemic, because of the previous pandemic, COVID-19, that is also ongoing still. Our experience with that and sort of emergency preparedness, and public health being able to be flexible in terms of pulling people from positions that they may already have routinely and sort of putting them into roles for incident command. And that structure for public health in this monkeypox response is known as HMAC. So pretty soon after the first case was identified here, there was sort of an urgent push to put together a group of people from various sort of divisions and parts of public health. So EPI, vaccine, the emergency preparedness, higher level administration, clinical services, communications, et cetera, to really address each of these things that you see listed here. So our duty as public health is really to foster public communication, not only to the general public, but also the community that was being affected. So a lot of thoughts about maybe what we did and maybe didn't do as well in terms of communicating with the LGBTQ plus community, as well as medical providers, having to get testing up and running. So who to test, where can people go, how is it done, how long does it take to get results? All of that needed to be sorted out and operationalized. Similarly for vaccine, where is it coming from, having to develop criteria, and then how we are going to document those things. And then treatment as well. Where does it come from? What's the process? How do we actually get it into the hands of people? So a lot of the sort of infrastructure, and I think the thought in terms of protocol development was already there from COVID-19 and was able to be adapted for monkeypox. Some argue maybe not quick enough, but I think it's better than having started from ground zero and nothing. So our role as a sexual health clinic, we really were kind of the go-to place starting in the middle of June for all things monkeypox. So we were getting referrals from communicable disease and EPI section in public health, private practice and public health clinics, patients who were calling in. It was pretty crazy, and really hats off go to all of the staff who were at the front desk manning the phones, and really they were the front line for kind of triage for all of this. We were the only public site for a while to have consistent availability for monkeypox testing and evaluation, and also one of the two sites that had access to treatment along with the Harborview Infectious Disease Clinic. So really everyone from the county was kind of funneling here in those early days, which was a lot to add on top of our usual workload in terms of seeing all of our patients for their sexual health needs. We also got the largest allocation of vaccine, and we're sort of told your objective is to get as many vaccines in as many arms as you can as quickly as possible. And so that really required us to pivot and sort of make a plan very quickly to be able to meet that objective. So again, as I was kind of thinking in my head, what all has happened and when did it actually start? It's crazy to think that this has all been in the last 3 months, but it has honestly felt like it's been 6 months. The first case in Washington was diagnosed on around May 23rd. And then we sort of saw the first patient at the sexual health clinic on June 14th. And then after that, you can see on this timeline, things moved very rapidly. We started mass vaccinating around July 25th. And then we created a dedicated vaccine clinic in early August, where we wanted to kind of separate the people who were coming in just for vaccine from the people who needed more detailed evaluation or other sexual health services. And then we moved to the intradermal vaccination around August 11th. We changed our supply or the equipment we were using to be able to get more doses out of each vial around August 23rd. And then August 29th, the most recent data point I have here, we kind of switched our database to be able to better track all of our patients and who's being followed and who's being treated. So I kind of broke up that timeline into 3 phases. So I'll just tell you about all the craziness that happened at each phase. So first, the early phase, I'm calling June 14th to around July 25th. So we would show up in the morning, and there would already be 100, 120 people lined up around the building at 9th and Jefferson and Harborview as soon as word got out that we had vaccine. And you can see a picture here that Matt Golden took in the hallway in those early days. People lined up and down the halls. It was sort of swampy. There were so many people that it like overloaded our air conditioning system. maybe wasn't the most, I guess, the best system for people in terms of like COVID and infection control, but we were obviously in sort of critical mass vaccination times. So at that point, we were doing monkeypox evaluations, and it took anywhere from an hour to an hour and a half per patient. And so, you can imagine, on top of all the other patients that we were seeing, how much of a toll that kind of took on us being able to get patients through in the clinic, but also on each clinician that was seeing these people. So initially, testing had to be done through public health. We actually had to call CD-EPI and get approval, who then had to contact DOH and tell us, yes, you could test this person. We had to send 2 specimens to the state lab that was in Shoreline, and the turnaround time was maybe not the best initially, anywhere from 2 to 4 days. And so, patients were very anxious, understandably, and sort of calling, like, how do I get my results? When are they coming in? They only came in by phone initially, contacting CD-EPI, and then we got a fax later on after that. As I mentioned, infection control is a big issue where we were trying to keep people we thought had monkeypox out of the waiting area with others who did not have symptoms, so trying to get them into a room as soon as possible. And then our infection control told us that we needed to do a terminal clean, essentially wait for environmental services to come in after each patient, and then do a thorough cleaning of the room before we could put someone else in there. So you can imagine sort of how the minutes stack up for these evaluations. Treatment was a separate thing. It took, up to an hour per patient. Initially was done through the Harborview ID clinic. And then we were able to sort of take that on ourselves, but still required a considerable amount of counseling, doing the informed consent, having to fax a paper form to Harborview, and then lots of CDC forms, which were a little bit onerous, let's say. In the beginning, that has now been streamlined a bit, thankfully, but that was a lot, at least initially, to do while we were figuring all these other things out. And then, as you see here on the right, in this picture, vaccination, we really had to pull people from everywhere. So, Matt, Mina, Julie, nursing staff, MAs, everybody was available, trying to vaccinate as many people as we could. And this is while sort of guidance was like changing hour to hour, essentially saying like, yes, we should vaccinate people who've had a smallpox vaccine. No, we shouldn't. And kind of trying to keep up with all of that in real time was a lot. And then, of course, initially there weren't really dedicated criteria. And then once we had those, there was a challenge with being able to kind of enforce criteria, specifically when we said really only gay, bisexual, other men who have sex with men, and trans people who have sex with men qualify. We had a lot of people who say, for instance, I'm non-binary. Can I get the vaccine? And sort of how we dealt with really trying to enforce that in a setting where we had lots of people around and we didn't really have the time to kind of go through that with every individual person. As I mentioned, the incident command happened 3 times a week. So for situational awareness and kind of coordination across all the public health divisions. And then research studies, we are known in the sexual health clinic for often having, 5 to 10 studies going at any given time. But a lot of that had to be put on hold, except for Project Detect, which still kind of tinkered along, thankfully, so that we could all kind of put our power and effort into this monkeypox response. And then Matt Golden had a great idea for testing existing specimens and sort of thinking about how we might move to eventually doing asymptomatic universal screening. And then Alora, who is one of our great infectious disease fellows who has actual EIS experience with CDC, thankfully came and started working with us in clinic, and she was able to set up a database for us to be able to more reliably track tests and how treatment was being administered. And then also another idea that was kind of crowdsourced from all of our staff was making a nurse kind of bat phone, a monkeypox line that we could use to triage calls from communicable disease and community providers. That kind of quickly became overrun with calls and like patients kind of calling back and providers saying, hey, I need to get somebody in. But I think it worked for a time and was a good idea while it lasted. Before I move on to this next phase, it looks like a couple of questions here. Let's see. Okay. Speak to more about what it is sharing bathrooms lends itself to transmission, and then other Okay, yeah, I will maybe save that question until the end. Happy to do that. Okay, thanks, Roxanne, for explaining what EIS is. Okay, so in the middle phase, which I have said is kind of July 26th to August 10th, we were really churning out vaccines. So at the peak of this, 350 plus patients per day, which if you think about how many people that is to get in and out, keep track of their names, the paperwork for getting them registered for the clinic, and then being able to put all of those vaccinations into a registry, that was a ton of people that we were seeing. And it really took a lot of coordination, even with security for line management, because initially they were sort of letting 100 people up at a time on the elevators, and that was not working. We needed to make a system to have people sort of brought up in waves, 20 at a time. So our staff would kind of look and see when the line got long enough, and then we would let more people up. We had to make our own kind of screening and registration forms because that was separate than what people normally do when they come into the clinic. So allowing people to stand in line, fill out their forms with their name and information. That way we could use that later to put it into the registries. That has, become a challenge in terms of now having, thousands of sheets of paper with patient information on it that we needed to get into the medical record, how we can do that data entry. And so Elizabeth, our manager, was doing incredible work behind the scenes to really obtain additional staffing for that, and was eventually able to get some people from DOH to kind of help with this administrative extra burden that we had. And then, as I mentioned, we were using Public Health Lab initially, but we needed to transition, I think, to UW's testing service. They got a PCR, homegrown PCR up and running pretty quickly. And so we were able to switch over to them, but having to think about how we get samples then to UW, how we interface that with our own electronic health record, and then how we pay for that. Because as public health, we have sort of a sliding scale for people in terms of the services here, but UW was not going to run the tests necessarily for free, and so we had to figure out how we were going to pay them for that. Alora, who I mentioned, and then Julie Dombrowski set up a system with our nurses to be able to do clinical follow-up with all of our patients who were diagnosed positive. And then we also developed a call schedule for all of our doctors to be able to do follow-up on weekends, because often we had a slew of people who were tested or evaluated on a Friday, and then their result might come in on a Sunday. And, again, understandably, people were very anxious. They wanted to know the results as soon as possible. And if they needed to be started on treatment, we needed to have a system to do that on the weekends. So similar slide to what I had before. You can maybe see the numbers are a little bit better now. So our evaluations are maybe not taking 90 minutes this time, but maybe more like an hour. So testing through UW helped a lot. Our turnaround time was cut in half, essentially. We were no longer having to get pre-approval, so that really sped up our processes. And we were able to just send our specimens directly from a courier over across the street to Harborview or to the East Lake Virology lab. And then thankfully, infection control also told us we did not need to do a terminal clean anymore, so we were able to forego that. But then every person who were seeing a patient themselves had to wipe down the room. And so that was a little bit of a burden, but I think still better than waiting for environmental services to come and do each room individually. And then in terms of treatment, still took a little bit of time to kind of counsel people and go through the whole process. But we were able to move to doing presumptive therapy, which I think was a game changer. So initially we were having to wait until someone had a positive test before we could offer them treatment. And what we were seeing was a lot of people got worse in those, 2 to 3 days when they were waiting for the test to come back from the public health lab. And so when we were able to evaluate someone and say, this looks like monkeypox to me, let's start you on treatment right away, presumptively without having a positive test yet, that was really, that was great for our patients. And it also saved us some work on the back end, because when our tests came back positive, we could just verify, yes, they're already on treatment. We don't need to do anything else, but maybe check on the patient to make sure that they're doing okay. And so Matt was able to get us our own stock of the TPOXX medication that we could store at the sexual health clinic. Again, a lot better for convenience. We could just go to our own storeroom and grab it and give it to the patient rather than having them go get it from the Harborview IDS pharmacy. And then I mentioned that the CDC forms were sort of slimmed down a little bit. In terms of vaccination, when our criteria were set, again, there were some challenges still with enforcing that. There were a lot of people, we think, that didn't necessarily meet criteria, but were very sort of worried about monkeypox exposure. And so specifically for some cisgender women, how we kind of dealt with that in the line took a lot of conversation and a lot of iterations about how we sort of handled that. Initially, we were doing subcutaneous doses, so that was the larger volume, 0.5 milliliters. And day to day, our vaccine supply, we were kind of waiting to hear from public health what number of vaccines we would be able to get for the day. And we kind of had to time it and say, all right, at 2 o'clock, we're going to run out. So we need to sort of cut off the line around 1:50 and make sure we can just get through the people that we have today. Thankfully, the virology research clinic that's here on the 11th floor of 9th and Jefferson was able to get us trained on how to do intradermal administrations of the vaccine, because they have several studies that they already utilize that method for. And we, interestingly, were considering doing this sort of novel intradermal microneedle system that would be able to sort of reliably and automatically deliver the same volume every single time. It was made by this Israeli company, and we sort of talked to them for a little bit about whether we could get those, but it ended up being sort of expensive, and we couldn't get as many as we needed to scale up our vaccine response in the time we needed, but we did at least consider it. It had worked well for the VRC staff. So in terms of other operations for our sexual health clinic, a big thing was our patient wait times have usually been pretty good. So more than not, people don't have to wait for more than 15 minutes when they come to the sexual health clinic, which we're kind of proud of. But during this time, our clinicians and our other staff were pulled to other areas. And so our wait times increased dramatically. Some people were waiting 4 or 5, 6 hours to be seen. As I said, staff had to be pulled to vaccinate and evaluate monkeypox. We were able to get additional nursing support to flex between the vaccine clinic and sexual health clinic. So that was very helpful. But often we had to halt our clinic early, in the morning or midday, which was not something we typically did. So, we did have to sort of say, if someone was coming in for just a routine asymptomatic screening for chlamydia, maybe we are not able to see you. We're not able to schedule you right now just because we don't have any availability and our staff is not able to handle that right now. There were also concerns about healthcare worker transmission, and I think that is actually still a big concern. Initially, we were not necessarily sort of doing full PPE for every single person that had all of the symptoms. So say, for instance, if someone just had, congestion or a little bit of a sore throat, it was sort of unclear. Is that monkeypox? Is that COVID? Is it, gonorrhea? We don't know. And so the infection control folks for Harborview were actually having us initially put every single person who went into a monkeypox room down on a log that we had to send to them because they were monitoring everybody to see if there was any transmission. There have not been any reliable transmissions from occupational exposures, thankfully, and we're not having to do that anymore. But I think a lot of our staff are still very worried because technically healthcare workers are not routinely eligible for vaccines. So that led to what you see here, a lot of stress, frustration with staff, and then of course burnout because they were doing additional work on top of their jobs they're normally doing. So I'm going to talk about how things are right now. So that was a lot distilled down, I think, just into a few slides, but it felt like it was, 4 months. So in terms of where things stand right now with our monkeypox response at the sexual health clinic, so as I mentioned, we have a separate vaccine clinic where people can go. They don't necessarily even need to come to get registered at our kiosk or check in with the front desk. They just get a clipboard and they fill out their information. They are sort of in and out. Most people are, able to register, hand over their paperwork, get a vaccine, and then they're out within 10 to 15 minutes, if that, depending on how busy it is that day. A lot of people needed a vaccine dose number 2. So some of you may know that a lot of folks from the community ended up going to Canada for their first vaccine because they weren't able to get it early on here in King County. And so we had a really big wave of people that needed the second dose. And so we were able to send out messages on my chart and also update our county website to let people know that vaccine dose 2 was available. We streamlined our workflows quite a bit, thanks to Meena Ramchandani, who worked a lot to get all of our sexual health clinicians to be able to prescribe tecovirimat. So initially it had only been the clinic physicians, but now all the clinicians can, so that helps a lot. When they go in and do their evaluation, if they, from their discussion with the patient over the phone, think that the monkeypox is high on their sort of list, their differential, they're able to just take the medication in with them, hand it to the patient. They can do presumptive therapy right there on the spot. So that saves a lot of time. Again, our vaccine clinic registration and criteria forms were streamlined. So that took a lot of work with our King County equity team and sort of figuring out what is the best way to have people self-attest to meeting the vaccine criteria without actually asking them to say, check, yes, you're a trans person who has been to a bathhouse. Because I think, when there are people over your shoulder and there's long lines of people, they don't necessarily want to write that. And I can understand how that could be potentially off-putting and stigmatizing to people. And then, of course, getting our forms translated into Spanish. As you can see here, we were able to get some signage in the halls as well for people to use QR codes to get their forms instead of taking the paper ones. And then Susan Buskin and others with public health created the survey that you see at the bottom here, sharing your thoughts on monkeypox. And so results for that hopefully to be forthcoming. And then in terms of our clinical workflow, I mentioned this a little bit already. It's a lot more streamlined now. So I think, some people can do it in 20 to 30 minutes, but I think more than not, it's taking about 45 minutes where the provider calls into the room first on the phone. They get their initial history from the patient. We did create dot phrases that makes it easier for people to kind of just go through and get all the information they need. The patient signs up for my chart while they're waiting for the clinician to go into the room so that they can sign and send their consent form back to us. The provider puts on all their PPE from this fancy cart that our staff put together. They grab all the supplies they need and then the medication from the room, and they leave that outside the door. They evaluate the patient, they collect the swabs they need to do, complete the whole informed consent process, and then they can just grab a bottle of TPOXX from right outside the cart if they need that. Then once everything's done, they take off their PPE, show the patient out, clean the exam room, complete all the paperwork and the labeling, and then they do their documentation using the set dot phrases. So still is a lot to do for each patient, but I think this is much better than where we were, a couple of months ago. So just for those who don't know, our new improved vaccine clinic, these are our hours, open Monday through Friday from 8 to 3 p.m. On Tuesdays, we start at 9:30. It is open to the public. Anybody can come and get vaccine. There's often a morning rush of, 25 to 50 people, but then after that, the waves are very much manageable, so people don't have to wait very long. And it's staffed by a mix of agency staff, float pool from Harborview, including some of the sexual health clinic staff that kind of bounce back and forth depending on how things are going for the day. And thankfully, Elizabeth and others set up this system where we've got all of these people who fill these roles, and they really make this a smooth process for folks. And we've gotten pretty good feedback from patients about it. And we now have DOH and public health staff that their only job is to just put in the vaccine information into the registry. So for scribing and then also registration so that we can get caught up on those. This is just an example of our screening checklist forms now, which went through a lot of iterations, but we think that they are okay now, and we've had them vetted by our equity team. Just an example, some pictures of our staff working in the vaccine clinic and sort of what a snapshot of our schedule every day looks like. So just wanted to show a few data points before I end here. So what our epi curve looks like for the sexual health clinic. You can see in orange, those are the counts by onset date, and then the blue are the counts by test date. So the first case, like I said, in early May, and then these data go up through the beginning of September. And then in terms of the number of people we've treated presumptively versus based on results, you can see that a lot of those cases in orange were only by results because that's what we were doing. And then there was a shift around the middle of July to where we started treating people presumptively, and you can see a lot more blue bars there. And then just another way to visualize that here on the bottom. Thanks to Alora for getting all of these data together. I think it's been very helpful, as I said, to transition to presumptive therapy for people. It's helpful for the patients and for us. And then just a few statistics from the sexual health clinic through Friday. So we have tested approximately 320 people in the sexual health clinic from June through September, about 229 negatives, 161 positives. And if we use the last case count that was released by the county on Friday, 400 total cases, about 40% of those have been diagnosed here, patients we've seen in our sexual health clinic. I actually think that number is a little bit higher. We're working on sort of getting the data caught up. I think it's probably closer to about 50%. So a lot of people that we're seeing here from the county. And then in terms of the number we've treated presumptively versus result-based, you can see that there based on the number of positive monkeypox tests. And really, we have not treated only about 12% of people. So the vast majority we are treating, and that's based on our sort of decision to have a little bit of a lower threshold to offer people treatment. So a lot of this I've said, but just to kind of summarize what I think the successes and the highlights have been for us in the sexual health clinic. I think we have been really able to kind of nimbly adapt to jump into action and serve our community. We've been a safety net for monkeypox when there have been a few other places that were ready to go in terms of their operational processes. Our clinicians have really gotten to be excellent evaluators of monkeypox, and we think that their ability to discern monkeypox versus something else has been very good. So we're actually going to write that up because we think that's worth sharing. And we are proud to have maintained really good clinical care for other sexual health needs, despite there still being COVID and all of this with monkeypox coming on in the setting of really high demand and limited staffing. So I applaud the resilience and flexibility of all of our staff. This has been an amazing effort on the part of all. So what are some of the challenges that we still have? I think there is a backlog of vaccine administrations. We are getting caught up. The reason that's important, we need to get those in, is because CDC needs those metrics in terms of how many vaccines we've given before they will give additional vaccines to our jurisdiction. We are a little bit behind on doing the CDC forms for tecovirimat, but we're trying to get caught up on that. Ideally, we would be able to get our results interfaced directly so they could be sent from the UW lab and put into our electronic medical record and not have to deal with faxes and the potential for human error with manual entry. Still figuring out how to have patients come in for clinical care after they had a monkeypox diagnosis. So for instance, if they have a gonorrhea infection that needs to be treated, do we have them come in when they have monkeypox, or do we just send them a treatment to a pharmacy, or have them come pick up medication at the clinic? And then really there's still a lot of questions remaining about what we should be doing and what patients should be doing. There are just many unknowns about transmission modes. Is it sustainable for us to continue doing presumptive therapy? We don't really have guidance on in terms of when or if people need a vaccination after they've had monkeypox. What happens, somebody said that they got their vaccine, they went into the elevator, somebody bumped against them and the vaccine squished out. What do you do in that case? These are all questions we don't have a good answer to, but we're trying to figure them out. And then just a few more challenges here. I think mainly it is, we just need more bodies. We're trying to work through a lot of hiring delays and figure out now that monkeypox is kind of coming to an equilibrium, how we can resume some of our prior services, sort of restarting research and things like that. Okay, our next steps. So whether or not we need to continue having this vaccine clinic, have a semi-permanent location for that, yet to be determined. I think we are hopeful to begin a universal screening study for people coming into our sexual health clinic, where we can offer them screening for monkeypox, even if they're asymptomatic, and sort of evaluate whether or not there is asymptomatic shedding that's happening in our patients. Lots of reports to come, hopefully, as we evaluate our data. And then finally get caught up on getting all of our CDC forms in, and really appreciating the support from the community. We just got word today that there's a centralized UW monkeypox kind of center for fielding calls and getting people in for treatment. So hopefully that will continue to offload us. Yeah, so many thanks for all of the people that you see listed here. This has been an incredible undertaking that we could not do alone, and this has been an amazing team to work with. I sort of jumped into this position after Lindley left. Literally within a week, monkeypox kind of descended upon us, and it's been a trial by fire, but it's been a great time, and I appreciate learning from everyone and really being able to collaborate to serve our community. So I will end with that. I think we probably have a few questions if there is time.
Thank you, Chase. That was really just amazing. And a lot of people have expressed a lot of gratefulness for the work that is being done in the sexual health clinic in the chat. I think, given that there are many questions in the chat, do you want me to just read them, or do you want to find the ones that are unanswered?
Sure, I can go back. So I guess there was a question about bathrooms and towels and surfaces. So yeah, that is one of the unknowns that we are still sort of grappling with ourselves. So I think CDC did put out a study where they went in and tested different surfaces, inanimate objects, as well as fomites, textiles, things like that, in an apartment for someone who was being housed there before they went into the hospital with monkeypox. And we have some data about maybe how long viruses can be culturable or live on surfaces, but like what that means in terms of our counseling for patients, we don't really know. So we're telling people, as much as possible, try to use a different bathroom or clean surfaces with bleach wipes, that sort of thing. But I think overall, it's probably not a significant source of transmission. Fomites certainly could be if you're sleeping on the same sheets with someone else. That is a possibility. But in terms of like you touched a sink handle or a doorknob, I mean, I'm not sure about that. These are unanswered questions that we even talked about just this morning on our clinical meeting. One question about uptake for the second dose, anecdotally hearing that demand for the second is not what it was. Yeah, I think that is probably true. We've had a fair number of people coming in for their second dose, and I think the demand has been high among the community. I recognize faces that came in for their first dose. But I do think that you're right in the sense that the sort of awareness and that was driven a lot by anxiety and kind of panic early on when we didn't know as much has sort of died down a little bit, and that may contribute to why we're not seeing as many people coming from the second doses, but interested to hear what others have seen and heard. Do you need to be a King County resident to come to the vaccine clinics? No, you do not. Let's see. Do we know, has there ever been a documented case of transmission from patient to healthcare provider? Thanks, Beth, for that question. I heard just sort of anecdotally that there was a report of that somewhere in the South, but I'm not sure. I think the person was not using appropriate PPE. The provider was examining someone without gloves on, without a gown. And so I think in the setting of appropriate use of PPE, that is not something that we are concerned about, and we have not seen any transmissions. If others have heard differently, please do chime in.
Chase, I was just looking this up because I saw Beth's question, and I listened to the weekly CDC call, and I feel like I'm usually multitasking, but I feel like someone from the CDC said there was one transmission, and that specifically the person had unroofed a vesicle. They didn't say anything about their PPE, but I think that's just a good reminder, is that these vesicles and lesions are very viremic, and so you don't have to unroof them. You do a vigorous swab on the top of the lesion, but you don't have to like pop the blister. And so that was what I thought I heard, but I cannot find any documentation of it. But that is what they said on the CDC call.
Yeah, that's a great point. Thanks, Hillary, for adding that in. Yeah, initially we were sort of told you may need to get fluid from the blister and unroof it, but we now know that's not the case. You just need to swab it over it vigorously. There's usually enough viral material there to give you a positive PCR if the person has monkeypox. Are we linking up with the local site conducting the TPOXX clinical trial? Yes. So to Brian's question, the UW Positive Research Center here in Harborview is going to be participating in that TPOXX clinical trial. So we will have access to that for people who want to enroll patients.
There was a question about the vaccine and myocarditis a little ways up, Chase, if you could get that one.
Yes. Let's see. Toggling two screens. Sorry. Yeah, I actually don't know, Nui, if there have been reports of that. I think that in some of the outbreaks that were occurring with a different clade in Africa that had been reported rare cases of encephalitis, myocarditis, pericarditis with monkeypox infection. But in terms of with Jynneos, I have not heard that. Maybe Anna Wald knows. I think that's always a concern, and part of why CDC is saying, if possible, separate the administration of Jynneos from the COVID boosters or COVID vaccines so that you're not sort of stacking that potential risk on top of each other. But I think they're still very, very rare. I don't know if others have heard.
To my knowledge, Jynneos has never been associated with myocarditis.
Okay.
So that is not a risk. It is a risk with other smallpox vaccines. It is not a risk in humans with this vaccine. So I think, the CDC doesn't always know best, and they are often sort of overly cautious. I actually don't think that guidance makes sense, and it might change over time. But just to state it again, there have not been cases of myocarditis or pericarditis associated with the Jynneos vaccine.
Thanks, Anna. And I think it is also important to say how much of the data and information that we are using comes from decades old information from a prior smallpox outbreak or different formulations of the vaccine, earlier generations than we have now. And so it's not really apples to apples. We're kind of guessing our best guess, and this is a different vaccine, a different clade, a different clinical presentation. So there's a lot we don't know. There's a lot of questions here. Okay, let's see. We may not get to all of these. I can try to save the chat and see if I can contact people if we do not get to all of them.
I think we should probably wrap up, Chase.
Yeah, that sounds good.
If you want to tackle one last question, and then we'll close things out.
Let's see. So one person asked about how long someone is considered contagious. So there's a range of time, but it's essentially until all of the lesions that you have scabbed over, and so that scab has fallen off and the new skin has grown over. And so that could be, anywhere from 1 week if someone starts treatment and it's very quick, up to potentially 4 weeks if they're not on treatment and it could take that long. So it's a range of time. We're not able to tell anyone stay home for just 2 weeks. You have to wait until your body sort of heals over completely.
Great. Thank you, Chase, so much. There are still more questions coming in, so we'll try to tackle the chat after we've ended the Zoom. Thank you, everyone who attended and shared questions. It was great to see so many people here today. I was thinking we may have to do a follow-up on this talk at some point in the future to get an assessment of the situation in a couple of months. Thank you, everyone. We have another Lunchbox talk coming up in December, I think, with Martina Morris.